Hello again, and welcome to Chapter 14, which is the cardiovascular system. This is a pretty fascinating system because not only do you never have to think about it at all, it's constantly working all of the time and for the entirety of your life. So it has to be a very well organized, very well maintained, and a priority for the rest of the body to maintain homeostasis. So let's go ahead and jump right in. So the cardiovascular system consists of the heart, blood, and blood vessels. And whenever we're talking about the heart, and we're talking about cardiac muscle, remember there's 3 different types of muscle: skeletal, smooth, and cardiac. So here we're focusing on just the cardiac muscle. That's the majority of the heart, and that's what actually helps provide that force to move blood through the heart. Once we finally move blood through the heart, then we use those blood vessels to actually get it to the tissues so that oxygen can get to the tissues and other nutrients. The anatomy of the heart. So the anatomy of the heart is located in the mediastinum. So if we draw a person here with, and again, I'm terrible at drawing people, so wow, something's really wrong with that arm, and legs. Here, let's say this is the diaphragm. The mediastinum is going to compose parts of the structures in the neck, plus the heart, and that's it. That's going to be our mediastinum. The heart itself is going to be surrounded by a pericardial sac, peri meaning around, cardial meaning heart. Let me change colors here. And that sac has multiple layers. The outer layer is going to be fibrous, and the inner layer is going to be serous, and in between those we'll have some fluid. Again, we like having fluid in between membranes because it helps reduce friction, helps dissipate heat, and helps protect organs from one another. Here's a picture of what's going on in the thorax. So here we have some lungs, the skeletal muscles of the rib cage, and some ribs, and then the heart right here in the center in the mediastinum. We can see that we've got some big blood vessels coming off of it and going into it, and we'll discuss those. And it's located anterior to the trachea, which is our windpipe, which we'll talk about whenever we get to the respiratory system. Here, this picture is also depicting the, does it have the layers of the, oh no, it doesn't have the layers edged out here. It's just showing you the pericardium as one layer, but if we were to actually zoom into it, we could see that it's 2 layers, and it kind of shows you that, where one is a little closer to the heart and one is a little farther away from the heart. So again, we don't want too much fluid built up around the heart. That's bad news bears. We do want a little bit, though, to help keep it separate from the other organs and help protect it, like we mentioned. All right, layers of the heart wall. So now we're talking about the actual musculature of the heart. We have a couple different layers that we need to talk about. The outermost layer is going to be the epicardium. Epi means above, so that's how you can remember epicardium. Pericardium means around, so we just talked about how we have the 2 layers of the pericardial sac, and then the cavity in between those is going to separate the outermost layer of the muscle from the rest of the pericardium. And then we actually have the inner layer of the muscle of the heart, which is myocardium, so myo referring to muscle, cardium again referring to heart. And then we finally have the endocardium, which actually the myocardium, I should mention, is probably the thickest out of all 3 of these. And then endo means within, so this is the most deep layer of muscular or cardiac muscular tissue of the heart. Here's a nice picture. So inside of the heart, so the chambers are on the right side of the picture here, and the outside of the heart is over here on the left side. Here it's even showing you the different layers of the pericardium, and then the thickness difference. So you can see that the myocardium is nice and thick right here in the middle, with the endocardium being on the right hand side or the more deep side, and then the epicardium being a relatively thin layer on the superficial side of the myocardium. Here's another view of that. So what we're looking at is an anterior facing view of the heart, with the apex towards the bottom left side of the person. Remember, whenever you look at a patient, you're always looking at their right and their left. So the apex points down and towards the left versus the base of the heart is towards the right. Here we're zooming in on what the myocardium might look like in comparison to the other layers of muscular tissue in the heart. Let's talk about the spaces within the heart and their purpose. So we have 4 total chambers. We have 2 upper and 2 lower, and each side is divided by right and left. The upper chambers are called atria or atrium. Atrium is singular. And then the bottom sides are the bottom chambers are right and left ventricles, or ventricle for singular. Each side laterally and each side superiorly and inferiorly is divided by a septum. The septum functions just to help separate blood from one chamber to another. Some of it's oxygenated, some of it's deoxygenated, and we don't want any mixing to happen. Some separations with the heart with the outside of the chambers. Outside you'll see a nice coronary sulcus, and the coronary sulcus, if you remember from neuro, you had gyri and sulci, or sulci, some instructors pronounce it that way. These are going to be the grooves, or the kind of the spaces, not the actual bumps themselves, but the grooves. And this is going to physically actually separate the atria and the ventricles, and you can tell this on the posterior aspect of the heart. On the posterior aspect of the heart, you can also see the interventricular sulci. This is going to separate the ventricles in the inferior half of the heart. And they're named for exactly where they are also. I didn't mention that. So the coronary sulcus actually follows where the coronary arteries and veins are. And then the interventricular, meaning within, in between the ventricles. So let's talk about what's coming in and out of the heart. So coming into the heart, we have blood going into the right atrium via the superior vena cava, inferior vena cava, and the coronary sinus. So we have three very important large vessels that all supply blood all to the right atrium. The superior vena cava is going to get a majority of the blood from the upper body, so head, neck, arms, versus the inferior vena cava is going to get everything else, so legs, abdomen, pelvis, toes, you name it. The coronary sinus, though, is actually going to drain blood from the heart. So the heart is a muscle. It needs its own set of oxygen and its own blood supply. So whenever we devote some of that blood to the heart, that blood also needs to be recycled and repurposed. So it also will go through the heart to be recirculated out to the lungs to get more oxygen. And so all of that venous blood is going to dump into the coronary sinus, and then the coronary sinus is going to dump into the right atrium, along with the inferior vena cava and the superior vena cava. You might see this abbreviated in the clinic as VC or IVC. I don't know if there's an abbreviation for coronary sinus. All right, so let's talk about where the blood is going after it leaves the heart. So this is all the blood that comes into the heart. Let's talk about the vessels that are leaving the heart. So the first big structure that's on the base of the heart is going to be called the pulmonary trunk artery. And it's named an artery because it's moving away from the heart, but it's actually carrying deoxygenated blood. So not all arteries are carrying arterial blood or oxygenated blood. This is one of those exceptions. The pulmonary trunk, it's a trunk, which means it's going to divide into branches. So we have a right and left, it's deleting things. We have a right and left branch coming off the pulmonary trunk. As you can imagine, the name pulmonary is going to mean that we're going to the lungs. So these right and left branches are going to go straight to the lungs to get oxygen. Whenever the blood gets oxygen via the lungs, and has to return back to the heart. So we're going to return via 4 veins. So A away, veins, I don't have a good way of remembering the difference there, but if you remember A away, and again pulmonary, so we're coming from the lungs and we're going back into the heart. All of this blood is actually going to dump into the left atrium to be recirculated out into the systemic circuit. Finally, whenever the blood has been pumped through the heart, it needs to leave to go to the systemic circuit or the rest of the body. And so it's going to do that via the ascending aorta, ascending aorta artery, if you want to be complete with that name. And that's going to carry all of the oxygenated blood to both head, neck, upper arms, thorax, abdomen, pelvis, lower legs. And there will be a bunch of branches off the aorta that will do that. One of the first branches of the aorta, if you can imagine here, I can draw a little heart here. And we have the ascending aorta, so it ascends and then it curves. Once it starts to curve, we call it the aortic arch artery. Then it's when it finally dives back posterior to the heart in the thorax and down into the abdomen. Then we start to call it the descending thoracic aorta. And then once it finally passes the respiratory diaphragm, then we call it the abdominal aorta. Here's a nice picture of what we just talked about. So blood is going to come into the right atrium via the superior vena cava and the inferior vena cava and the coronary sulcus, which is not listed here, but it's on the posterior aspect of the heart. Then that blood will collect in the right atrium, go into the right ventricle, and then leave out the pulmonary trunk artery to go to the lungs to get reoxygenated. Once it gets reoxygenated, it's going to return via the left and right pulmonary arteries, not the left and right pulmonary arteries, the left and right pulmonary veins, and that all of that blood is going to collect into the left atrium and then get contracted into the left ventricle, and then finally get ejected out via the aorta to the rest of the body. So how do we control what's going on between the atria and the ventricles? Well, we have some valves, and these valves are really important to maintain the right amount of blood in each chamber. You don't want too much volume and you don't want too little volume, and you want to give enough time for there to accumulate enough volume in each chamber. So each of the sides of the heart are going to have two valves, one on each side, and we're going to call those the atrioventricular valves because they're separating the atria from the ventricles. So that's how you can describe either valve. You can also be more specific and talk about the right versus the left atrioventricular valves. The ones on the right, or the one, on the right is also called the tricuspid valve. It's called tricuspid because it has three cusps. So if you look at it, if you kind of do a transverse cut through it, you'll actually see kind of this like bulby function here, or a bulby, I don't know how to call it, like three semilunar space, it's not semilunar, sorry, three like half moon type valves that will open and close. So that's why it's called tricuspid, versus the left side is bicuspid. So instead of this three, it has two. So it looks more like this if you look at it at a transverse plane. Each of these ventricles, each of these valves, in order for them to be really good at what they do, they need to have a set of their own muscles in order to help really tightly close it and really tightly open it and do it really quickly. So each of those are going to be attached to tendons, just like all muscles are attached to bones via tendons, and then those tendons are going to attach to big muscles. This kind of turns out to look like a ladybug once I'm all done. That's fun. Okay, so the tendons are called chordae tendineae, and then the muscles are called papillary muscles. And those papillary muscles you can nicely see in this picture here. So the papillary muscles, you can see those chordae tendineae here, and then the papillary muscles on the ends. And actually, I don't really know why they labeled it here. Really, they should label these as the papillary muscles. Then we have two other types of valves that we need to talk about, and these are the valves that are going to be in the aorta and the pulmonary trunk arteries. These are semilunar valves, and this is why I hesitated and corrected myself on the previous slide. So they're semilunar in that they're not full like moon shapes, but they're like half shapes, so they kind of look like this. Wow, no, they kind of look like this. And so you can imagine that we have a couple of those. So if we look at a transverse plane of that, you can actually see cusps like this in half moon shapes. And these aren't quite as strong as the atrioventricular valves because they're not connected to their own musculature, and they're not coordinated by muscles to open and close. They're totally coordinated by pressure. So there needs to be enough pressure in order to open these valves, and then they'll immediately shut right behind them. So the one that is going to be in the pulmonary trunk artery, we will call the pulmonary semilunar valve, and the one that is in the aorta is going to be called the aortic semilunar valve. Here's a nice picture. Oh, good. So my terrible drawings will hopefully make a little bit more sense now. So this is a top-down view. We're looking at the base of the heart. Anterior is here at the bottom of the page. Posterior is on the top side of the page. And here we're looking at the aorta. If we cut through the aorta, that would be here. And if we cut through the pulmonary trunk artery, that would be here. And so here you can see nicely the semilunar valves. Then pictured down here, which, and also the semilunar valves don't have as much supporting structures. They're just flappy, versus the atrioventricular valves on either the right and the left side, the right side here, left side here. You can actually see some nice like tendons, which eventually attach to muscle. You just can't really see that from this view. So this is showing you all four of the valves, the two atrioventricular valves, and then the two semilunar valves. All right, so I kind of already mentioned this a little bit in a previous slide, but the actual order of how blood flows through the heart is really important to understand. So before we talk about order of where things are going, it's important to understand that things are moving together. So when one atria contracts, the other atria will contract at the exact same time. When one ventricle contracts, the other ventricle will also contract at the same time. And this is to make sure that the blood isn't just stuck on like one side of the heart versus the other. They're actually both pumping at the same time. So you can imagine that if we have those four chambers, both atria are going to contract, and then the ventricles are going to contract, and then the atria are going to contract again, and then the ventricles. And this will help keep blood moving in this fashion, and out, and then back in and out to the rest of the body. And that squiggly drawing will hopefully make a little bit more sense here after this. So this is what we're saying here. The two atria are going to contract while the ventricles are relaxing. And anytime anything is contracting, that means we're pushing blood somewhere else. Versus while we are relaxing, we're allowing for things to fill. So we're allowing for the ventricles to fill with blood while they're relaxed. And then the opposite is also true immediately after. So after the ventricles are filled with blood, then they're ready to contract and push blood back out to the rest of the body. So either via the pulmonary trunk or the aorta arteries. So they will contract and push all that blood out while the atria relax and fill with blood from the superior vena cava and the inferior vena cava and the coronary sinus. I already mentioned this in a previous drawing, but all deoxygenated blood is returning to the body via the right atrium. So this is right and this is left. All that deoxygenated blood is going to come back in here to get recirculated into the lungs to get oxygen. Once that blood pools into the right atrium, then both sides of the atria will contract, and that blood will move into the right ventricle. Then the atria will relax and continue to fill with blood while the ventricles start to contract, and they will move blood out into the lungs. Then after they go to the lungs via the pulmonary trunk artery, the lungs will reoxygenate the blood, and then all of that blood will travel back into the left atrium via the four pulmonary veins. It will all fill in the left atria. Blood will pool. Atria will contract. Ventricles will relax. All that blood will pool into the left ventricle. And then the left atria will relax again. Left ventricle will fill with blood. And then once it's full enough, then it will pump it out to the rest of the body. But this is happening simultaneously, right? We don't have just like one pocket of blood moving at a time. Both things are happening on the same side of the heart at any time. So that's why both sides of the atria have to contract and both of the ventricles have to contract in order to actually keep blood moving and we don't like pile up anywhere. And we already mentioned this. And here's a nice picture. So here's our lungs. Here's our heart. And here we have blood coming in from the superior vena cava, and the inferior vena cava, and then the coronary sinus, which is on the posterior aspect of the heart. All that blood will pool into the right atrium. Atria will contract on both sides, pull that blood into the right ventricle. Blood will pool in the right ventricle. Then the ventricle will contract, push blood out to the lungs via pulmonary circulation. It will get reoxygenated in the capillary beds of the lungs, which we'll talk more about when we get to the respiratory system chapter. Then all that oxygenated blood will come back via four pulmonary veins into the left atrium. Blood will pool, atria will contract, blood gets pumped into the left ventricle pools with blood, then finally contracts and pushes all that blood out to the semilunar aortic valve through the aorta and out to the rest of the body. Then the body uses all that oxygen and nutrients, and we do this all over again. Okay, so now we have to have a method for making sure that the atria contract simultaneously and not at the same time as the ventricles. So that's where we're going to talk about the conduction system of the heart and how we actually conduct the whole thing. So just like a conductor of an orchestra. So we have a couple nodes, and each of the nodes are going to talk to each other. So first we have the sinoatrial node, SA node for short. Sino, I forget what sino means, but atrial we're talking about in between the atria. And the SA node will then, once it receives its signal, then it will talk to the AV node or the atrioventricular node. So this is in between the ventricles. And then the AV node will tell the ventricles what to do. That's generally what's going on here. So let's dive a little bit deeper. The SA node is the pacemaker of the heart, and this is what initiates any impulse or any initiation of any heart contraction. So the reason why the SA node is this and not the AV node is because the SA node is first. And if we, for whatever reason, don't hit the SA node first and we hit the AV node, then we're going to go into AFib or ventricular fibrillation. Oh, Jesus. Fibulation? Ventricular fibrillation? I think I'm misspelling it. Anyway, doesn't matter. Too much for this course anyway. But that's where the ventricles are out of sync with the atria, and so they're trying to contract first before the atria, and then this makes it really inefficient to actually pump blood through the heart. So whenever they have to reshock you or reset the heart, then they want to reset the SA node so that it again becomes the pacemaker of the heart and continues setting the pace of the contractions of the heart. So the SA node does this, and then it talks to the AV node. The SA node will tell the atria to contract. Then it will, at the same time, it'll tell the AV node to tell the ventricles to contract. And there's a lot more space of ventricle tissue than there is atrial tissue. So we have a little bit more of space that we have to cover. And so because of this, we have some branching of the AV node that we need to talk about. So after the AV node, then comes the AV bundle, and then the AV bundle diverts into the bundle of His, named after some guy, I don't know who it is. But then in the bundle of His will talk to the Purkinje fibers, and those Purkinje fibers will actually talk to the walls of the ventricle. Now this makes sense for a couple of reasons. So let's say I draw a heart like this, and my SA node is going to be about here, and my AV node is going to be about here. Nerve signals travel really, really fast, much faster than a muscle can contract. So we know that once the SA node gets fired and it fires and it's telling the atria to contract, we better make enough time between the atria and the ventricles contracting in order to make sure that there's enough time for there to be enough blood into the ventricles before the ventricles contract. So that's why after the SA node fires, it talks to the AV node, but then the AV node has some paths that it has to take before it can finally actually tell the ventricles to contract. So some time has lapsed so that there's enough time for enough blood to actually fill into the ventricles. And so that's why we have these bundles that we need to learn. So AV node to AV bundle, then bundle of His, and then finally Purkinje fibers. Here's a nice picture. First, the SA node over here, sinoatrial node. It's not quite as it's not really quite as central between the two atria as you would imagine it to be, but it's pretty close. But it's very near the AV node, and then the AV node just sits relatively center in between the two ventricles, but superior to the two ventricles. Then we finally have the AV bundle, then we finally have the bundle of His, which I don't even think is labeled here. No, it's not. But then finally, ultimately, then we branch out to the Purkinje fibers, which are all across the myocardium, and they will finally tell the ventricles to contract. A cardiac cycle. So how do we name what's going on at what point throughout this blood moving process? So one full cycle is where we have blood coming into the atria, into the ventricles, and then leaving. And we have some terms to describe what's going on for each of the chambers as this is happening. So and again, just as a reminder, when the atria are contracting, the ventricles are relaxing. And when the ventricles are contracting, the atria are relaxing. But you never want to have both the atria and the ventricles contracting at the same time, because then that would be chaos and nothing would actually really move anywhere. So when we talk about a contraction, we actually have a term called systole, and systole is where there is the first initial contraction happening of the heart. While the heart is relaxing, either the atria or the ventricles, then we call that diastole. And you might have heard this before because it comes in terms of blood pressure. And in blood pressure, we have the systolic number over the diastolic number. And usually the systolic number is a little higher than the diastolic number, which should make sense now because we would assume that pressure for a contraction phase is going to be much higher than the diastolic phase. Okay, let's talk about what happens whenever blood is actually leaving the heart via the aorta and where it goes. So once we are leaving the left ventricle via the aorta, we have all of this oxygenated blood and it is traveling through the systemic circuit. In the systemic circuit, it's called systemic because it's everywhere, and essentially everything but the lungs. And when all of the blood then leaves the systemic circuit, it all returns back to the right atrium as deoxygenated blood. The systemic circuit can be divided into a bunch of different divisions. Some of the ones that we list here are the coronary circulation, so this is blood that actually goes to the heart muscle itself. And then we also have hepatic portal circulation, and the hepatic, anything hepatic means liver, and this portal is, we'll talk about what portals are later in this semester, but this is essentially providing all of the blood to the digestive system to help clean out any debris that wasn't already previously circulated. Well, that wasn't already previously cleaned up is what I mean to say. Then we have the pulmonary circuit, and the pulmonary circuit will carry blood to the lungs so that it can actually get O2, so that it can come back to the heart and get pumped into the systemic circuit. We also have a cerebral circuit, and this is all of the blood that goes directly to the brain. And this will always have 20% of the ability of the heart to produce and pump blood towards the brain. And if things start to shut down, it doesn't matter. 20% of the blood will still go to the brain as a reserve. We also have different circuits for fetal circulation whenever there's a fetus in mom. Fetus doesn't use their own lungs or their own liver, so we have to have a circuit to help bypass that as those organs develop, so that we use mom's oxygen and mom's liver to help mom's lungs to get oxygen to baby, and mom's liver to help clean out toxified blood in baby. All right, let's talk a little bit about what's going on in a blood vessel itself. So both arteries and veins have 3 layers. We've got an intimate layer, tunica intima. We've got a medium layer, tunica media. And then we've got a outside layer, tunica adventitia. I've heard this pronounced many different ways, so have at it. The innermost layer, so if we're looking through a vessel and we had these 3 layers, right? We had the tunica media, tunica intima. The space in the vessel is going to be called the lumen. Lumen will be used for a lot of different vessel type structures in anatomy. And then whenever we have an artery talk to another artery directly, but it changes its names, then we call that an anastomosis. So right here would be like an anastomosis. Oh, but it's spelled right here, so I don't even have to do this, an anastomosis. Typically to denote this in notes or with or in medical charts, you might see it as a diamond in between the two. So this means that there's one artery here and another artery here, and they share a physical connection at some point, and that physical connection is called an anastomosis. Sometimes these connections actually allow blood to pass through. Sometimes they don't. They just actually join, but they don't actually pass blood back and forth between one another. But you just are responsible to understand what an anastomosis is. All right, let's compare arteries to veins. So arteries are going to be much thicker and stronger than veins, and that's because they'll actually contain smooth muscle within them. So in that tunica media. Arteries are the bigger structures that you can actually see with like the naked eye, but then those branch off into even smaller arteries that you can't really quite tell with the naked eye, and we call those arterioles. And then arterioles branch into even smaller vessels that we definitely cannot see with the naked eye. We'd have to use a microscope, and we call those capillaries. And capillaries are really, really thin. They're 1 cell layer thick, and that's perfect because that's exactly where we need to actually allow gas to diffuse from a high to a low concentration, and in order for waste to come into the vessel so that it can be carried back into either the liver or the kidney to be cleaned. As we're traveling back via the deoxygenated supply or back into the heart, we're going to travel via venules. Venules are really, really small versions of veins. Again, you can't really see venules with the naked eye, but you can see veins with the naked eye. The veins are going to be less elastic than arteries. And what does elastic mean? Elastic doesn't mean like what you would think like an elastic. Well, I mean it kind of like what you would think for like a hair tie, right? Like you can use a hair tie. Depending on how nice you are to it, you can use a hair tie multiple times, and it might always snap back to its original shape. or you might use it one time and stretch it too far, and then it has a really hard time coming back to its original shape. So arteries are those really good hair ties, the ones that you can depend on, the ones that can always snap back to their original shape. Versus veins don't have that ability quite as much. It's partly because they don't have enough muscle in their structure in order for that to happen for veins. But veins are special in that they have valves, and these valves are one-way valves, and they help move blood back up to the heart. In arteries, we have that smooth muscle. We can push blood out and away to the body wall and limbs, to the tissues. But whenever we try to return blood back to the heart, we don't have a really good mechanism to actually fight against gravity in order to get that blood back to the heart. So in order to do that, the veins have evolved these valves, and those valves will help segment the blood slowly but surely back up to the heart. Here's a nice picture of what's going on with an artery on the left side and a vein on the right side. Pay attention to the tunica media. The smooth muscle in the artery is much thicker than the smooth muscle in a vein. So we still have a little bit of structure in the vein, but not a lot. Other than that, this is just vocabulary. So understanding the difference between an artery, arteriole, venule, and vein, and what's the function of a capillary in between the two. All right, let's talk about some major ones that we definitely need to know. So right immediately off of the heart, right after blood pools in the right ventricle and gets shot through the aorta, we have a small outpocketing at the base of the heart where the left and right coronary arteries come off from. So the right coronary artery is going to travel in between the atria, supply the side of the heart and then the back side of the heart, and in between the ventricles on the posterior aspect of the heart. And then the left ventricle is going to do the same thing. It'll have a branch supplying the anterior portion of the heart, and then a branch traveling around the side of the heart and towards the back of the heart to supply the ventricles. And those right and left coronary arteries also have additional branches, but we only expect you to know the right and the left coronary arteries, so coronary referring to heart. And these are arteries that are supplying blood directly to the heart tissue itself. After that, we have a couple additional branches off of the aortic arch artery. The first branch on the right side is going to be called the brachiocephalic artery. And before we even talk about what it does, let's use some vocabulary to figure out what it might do. So brachio refers to branching. Brachio refers to branching, and then cephalic means towards the head. So we have some branching with some arteries that are also going to be supplying the head. And that branching has two big branches that come off of it. The one that's going to the head is the right common carotid artery, and then the one that's going to the arms is going to be the right subclavian artery. So if we have this off the heart, like this, we have the aortic arch artery. We're going to have the brachiocephalic trunk artery, and that's going to give off two branches, one being the right subclavian artery and the other one being the right common carotid artery. And you have to include common as part of the answer because eventually the carotids turn into different branches and those have different names. So before they even break off in those branches, you have to say common first. All right, then after the brachiocephalic artery, then we have the left common carotid artery, which will also go up to the brain, supply the left side of the head and neck. And then we have the left subclavian artery that will supply the left arm, which is the third branch down here. This looks a little different in animals. This is usually where some variance happens, but in humans this is pretty consistent, about 90+% of the time. All right, so what happens when our aortic arch turns into the descending aorta, the descending thoracic aorta in the thorax? We're going to give off a branch for each pair of arteries. So we'll have, for each pair of ribs. So we'll have 10 on one side, 10 on the left side. We'll also have some arteries supplying the bronchi of the lungs. We'll also have some arteries that will supply the esophagus, but because the esophagus is bunched up right next to the aorta back here. And we'll also have some arteries called phrenic arteries. These are named phrenic arteries because they're traveling along with phrenic nerve, and these are actually going to the respiratory diaphragm. All right, once we finally pass the thoracic region, we pass the respiratory diaphragm, and now we enter into the abdominal region. So for context, we have the liver here, We've got our stomach here, we've got our spleen back here, we've got some kidneys here, some guts, and then we've got our pelvis here. So, wow, that's a terrible picture. It kind of looks like a monkey with a sad face. This is strange. But anyway, liver, stomach, spleen. All right, so coming off of the abdominal aorta, we have some major branches that we need to talk about. First is the celiac trunk artery, and this is going to supply blood to the liver, stomach, and spleen. So this is where it's really important to understand where organs are, because even if you get lost in the naming conventions of what's what and why is it named that, if you can at least have an idea of where the organs are relative to that artery, it's probably going to be named for the organ that blood vessel supplies. So it's named celiac because celiac refers to the liver. So that's why it's named celiac trunk. Then we have two other big branches called the superior, being a little bit higher than the inferior mesenteric arteries. These are called mesenteric arteries because they're supplying the blood to the mesentery, and the mesentery is helping hold all together the small intestines. Then we have the right and left renal arteries, renal referring to kidneys, so these are going to be coming right off the abdominal aorta. Then we have the right and left gonadal arteries. Those are going to come off about where the renal arteries are, and those are either going to go to testes or ovaries, depending on if it's a male or a female. And then we have lumbar arteries. Those arteries are going to go towards the just superior to the sacrum and supply the lower back region, the lower back musculature region. And then we finally have the right and the left common iliac arteries. So again, just like the common carotids, we have common iliac, which means that those eventually branch again. So if we picture the inferior portion of the abdominal aorta, it's going to branch into the common iliac arteries, and then the commons are going to branch again into external and internal branches. So that's why we need to differentiate between common, because common then eventually turns into external and internal. The external iliac artery turns into the femoral artery. So femoral artery eventually turns into that. And femoral, named femoral because it's following the femur, the bone of the thigh, the big bone of the thigh. So femoral artery, that's a nice big hunk of an artery. All right, let's talk about some veins. Veins are generally closer to the surface than arteries, and this is because they don't need to be immediately next to the tissues. They can be just kind of adjacent to the tissues. B, I think this is also a protective feature, because if you cut an artery, that's really, really bad news bears, but if you cut a vein, there's not a lot of pressure in veins, so it's easier to recover from. There's actually an interesting story with veins with the upper arm. So in the cubital fossa of the upper arm, so if this is my arm and I have this person flexed, 2, 3, 4, 5, like this, and if we were to look at just this area, whenever they used to bloodlet, back in the day, I don't know whatever time period that was, whenever they used to drain people, if they came in sick, they would come see the doctor, and the doctor would drain them of blood. They would always prick a needle somewhere in here to aim for a vessel, and they always thought that they were aiming for an artery, but they were actually aiming for veins. And thank God that they were aiming for veins, because if they had aimed for arteries, then that person would have bled to death. So there's actually a tendon right here, the bicipital aponeurosis, which is a nice tendon that comes right off of the biceps brachii, and that actually separates the veins being more superficial than the arteries being deep to it. And so they were actually pricking the veins. They didn't realize that they were not pricking arteries, but we call that the grace of God tendon, because, and not to be like religious or anything, it's just what it's called, the grace of God tendon, because it actually saved a lot of people back at that time. Anyway, so if that helps you remember that veins are more superficial, awesome. If that doesn't help you remember it, then just take a look at your hands and the tops of your feet. It's more easy to see bright blue veins than it is bright red arteries, right? So you can always tell on your own body. Eventually, all the veins will finally converge onto superior and inferior vena cava, and then coronary sinus draining blood back from the heart, and that all goes into the right atrium of the heart. Veins are typically often named the same as arteries, so where one artery runs in one direction, the vein will be right next to it, running in the opposite direction, and they'll probably have the same name. There's very few places in the body that they're different veins, and usually there's a reason why. All right, so let's talk about some veins in the upper arm. Again, these are going to be named very similarly to the arteries. So even though we're talking about veins here, you should know that there's going to be a paired artery there as well. If we're talking about the anteforearm, so the forearm of the upper limb, we'll have two main veins, radial and ulnar veins. These are going to be following the radius and the ulna bones. Those will eventually dump to form brachial vein. And brachial vein will eventually dump into axillary vein, and axillary vein will eventually dump into subclavian vein. Also dumping into axillary vein is cephalic vein and basilic vein. Cephalic meaning towards the head, basilic, I forget what basilic means. Sorry about that. But all of those will also dump into axillary vein, and then vertebral vein, this is going to be dumping blood from the vertebral column. That will dump into subclavian vein, and then internal jugular vein, this is dumping blood from the brain, internal structures of the brain, and that will also dump into subclavian vein. And then finally, remember that subclavian dumps into superior vena cava vein. Okay, so I guess I kind of jumped the gun. Subclavian vein then dumps into right and left brachiocephalic veins, and then those veins dump into superior vena cava veins. Superior vena cava, there's just one superior vena cava. We also have veins called azygous vein. We have azygous and a semi-azygous and a hemiazygous vein. These are just adjacent veins that help drain blood in a certain area. The azygous vein, specifically is draining the thoracic region, or it's helping drain the thoracic region. All right, veins in the lower extremity. So we have anterior and posterior tibial veins, named tibial because it runs right along the tibia bone. We have perineal vein. Anything perineal, see this is old terminology, should be changed to fibular, because it runs along the fibula bone, right? Yeah, fibula, yeah. Then we have popliteal, which is the back of the knee, femoral, thigh veins, and those all dump into the external iliac vein. External iliac vein turns into the common iliac vein, and we have this on both sides, right and left. We also have a large vein that, if I drew a person, so we have the aorta, common iliacs, external, internal. If we were to zoom in here, and let's say this is like a knee, there's a large vein that travels down the medial aspect of the leg on both sides, and it's really long and it's really thin, and I forget what saphenous means, but it's called the great saphenous veins, and those also dump directly into femoral vein. The reason why we point out saphenous vein is because saphenous vein has a lot of clinical applications. It's really a great site for injections, A, and B, if you're trying to reconstruct anything in the lower leg, then you might use great saphenous vein to repurpose it into something else. Last but not least, we have the right and left gonadal veins. Gonadal meaning testes and ovaries. So these are going to be draining those reproductive structures. We also are going to be draining blood from the kidneys, so right and left renal veins. However, all of the blood in the, not all of the blood, all of the blood that is anterior to the gonads and the kidneys, so digestive tract essentially, is going to be drained via the hepatic portal vein and the hepatic portal system. This makes sense because everything in the lower half of the body hasn't really been like toxified or exposed to anything that might have toxins in it, versus everything in the digestive tract might have toxins in it. So it needs a second set of filtration. So it's going to be filtered through the liver, and all of that blood is going to be pulled and dumped into the hepatic portal vein, which dumps into the liver via the right and left hepatic veins and then into the liver. All right, so here's a nice summary of what's going on. But before we finish, I want to take a moment to show you what things look like in a more three-dimensional format. I think this will be really helpful for the heart. So here we have a skeleton, and I added on just kind of one basic layer of the arterial supply. I'm going to go ahead and highlight the sternum here and hide that so we can zoom in on just the heart. You can actually see it pumping here, which is really nice. And this is an anterior view. So here we have the aorta, the ascending aorta, the aortic arch, the branches of the aortic arch, and then it descends inferiorly and posterior to the heart as the thoracic aorta. So I'm going to go ahead and hide the skeleton and just focus on the heart and its tributaries. So, like I said, and let's just talk through blood supply actually. So all of the blood that is needing to be reoxygenated from the rest of the body is going to travel and dump into the right atrium, which that's going to be the auricle. There we go. Right atrium. And all of that blood is going to be dumped via the superior vena cava and the inferior vena cava, which is not highlighted here, but it would be inferior to the right atrium. All of that blood is going to dump into the right atrium and then travel down, contract. Once the atria contract, then it pushes that blood into the right ventricle. And then once that blood pulls in the right ventricle, it will pump out via the pulmonary trunk artery. And the pulmonary trunk artery will branch out into the right and the left pulmonary arteries to go to the lungs to get reoxygenated. So we can imagine the lungs here on either side. Then once it goes into the lungs to get reoxygenated, it travels back via 4 pulmonary veins directly into the left atrium. And then finally contracts back into the left ventricle and then out to the aorta and the rest of the body. So let's actually take a second to look deeper into the heart structure. So I'm going to hide some structures. So I just hid a outer layer of the right atrium, and here you can see the pulmonary trunk artery dumping in this hole. Here, let me get a pen here. So dumping in this hole. And then you can also see the inferior vena cava also dumping in that hole. And then what you can't see in this image is something from the coronary sulcus, and that would also be dumping in this space as well. And then all that blood is going to travel into the right AV valve, or the right atrioventricular valve, and eventually into the right ventricle. So let me undo that so we can continue here. All right. And 2 more times. Okay. So now let's take a top-down look at what's going on. So here we can actually see that tricuspid valve contracting and relaxing, and you can imagine that blood is pooling in the right atrium, which is open here in this view, and then once it finally is ready to get contracted and pushed down into the ventricles, it will do that. You can also kind of see on the left side the left atrioventricular valve, and you can see how in this model that both are contracting and relaxing at the exact same time, so that blood is moving in a very organized fashion through the heart. Okay, now let's do a bottom-up view. So let's remove a wall of the ventricle. So here we're looking in the wall of in the chamber of the right ventricle, and here you can see blood coming in from the right side here on the right atrioventricular valve. You can see those chordae tendineae attached to those papillary muscles, and those papillary muscles are helping open and close those valves. Then you can imagine all that blood pools here in the right ventricle, and then eventually will get pushed out through the pulmonary trunk, the pulmonary semilunar valves, and that will allow all the blood to get pushed out through the pulmonary trunk artery and out to the lungs. Then once we finally come back from the lungs via the 4 pulmonary veins, and I'm going to hide those immediately. I'm going to hide the aorta here for a second. Okay, we're into the left atrium. We can imagine that the left atrium fills with blood, then the left AV valve opens. Then we can see the left aspect of the heart. Maybe. Yep, and now here we're in the left ventricle of the heart. Sorry, let me get this in a better view here. Okay, so anterior is on the left side of the page now. Here you can imagine that blood is being contracted into the left ventricle. Again, we have those chordatidae and papillary muscles helping open and contract the bicuspid valve on the left side. Then we finally fill with blood, and then all that blood gets pushed out through the aortic semilunar valve, right here, and out through the aorta and out through the systemic circuit. So anyway, I know that this is kind of a complicated model. You're not going to be tested on this model. I just think it does a really good job of showcasing what's actually going on and helps give like a nice visual, because some of this stuff is like really three-dimensional and complex to really understand, and so I think it helps having some moving parts. This was brought to you by the application called Complete Anatomy, which is an awesome application, especially if you have the right tools to use the augmented reality option here. This app is great. If you want more information about it, I'm happy to chat. Just reach out to me. All right, thanks so much.